Stop. Okay, thank you everyone today for joining this meeting, and on behalf of Glenmark, we would really like to thank the audience today who have come in to hear on a very new and hot and burning topic, which is currently in the limelight. To discuss about that particular topic, we have with us Dr. Vijaya Arvinda, who is an MD Pulmonary Medicine. Also, sir has received fellowship in thoracic endoscopy from National Cancer Center, Japan, fellowship in pulmonology, Christian Medical College, Bangalore. And today, sir will be talking about his clinical experience on post-COVID lung fibrosis. Sir has several accolades under his name, and he has been one of the experts right now in treating post-COVID lung fibrosis cases. And it will be a good learning session for all of us to hear from Sir about the treatment and how do we manage post-COVID lung fibrosis. Before I hand it over to Sir, I would request everyone in the audience to please be on mute while the presentation is going on. If you have any questions during the presentation, please type in the chat box and we will take it up at the end in Q&A. Without wasting much time, I would hand it over to Dr. Vijaya Arvind to proceed. Over to you, sir.
Thank you for the kind words of introduction. So very happy Teachers' Day to everyone. I'm happy to have this presentation done on the Teachers' Day. It will be a memorable one for everyone. So straight away going into the topic. So I am here to discuss about post-COVID lung fibrosis. Before beginning of this topic, I would like to say that it will be better if we rename the topic as post-COVID lung sequelae. It is better to name the topic as post-COVID lung sequelae and not fibrosis. Why I'm saying this, you will come to know at the end of the session. So my outline of the presentation will be, first I'll be talking a little bit about the pathophysiology of COVID-19. Then most importantly, to understand fibrosis, we need to be good at reading CT scans and chest x-rays. So I'll be talking about x-rays, CT scans of COVID-19 pneumonia patients with lung fibrosis. I'll be throughout this presentation, I'll be going through a lot of case scenarios to help us understand better actually what is happening in patients who had COVID and how they end up in fibrosis, and whether the fibrosis is going to continue, like how it happens in other diseases like idiopathic pulmonary fibrosis, or is the fibrosis getting resolved. I'll be explaining it through the case scenarios which I have come across. We'll be dealing with the antifibrotic molecule nilotinib, and it will be compared with pirfenidone. And at the end, I'll be talking about what is the management of post-COVID lung sequelae. I'm not saying it as fibrosis, I'm saying it as post-COVID lung sequelae. Okay. So this one here, what is the basic of COVID-19 pneumonia, which every treating physician should understand. So initially there's a viral response phase, and second is the post-inflammatory phase. The post-inflammatory phase is the one which causes the damage in the lung. And in the process of healing, if the healing is not going to happen in a regular manner, or it is going to happen in a disordered manner, then what is going to happen is fibrosis. So it is the post-inflammatory response done, and in the due course of healing, due to impact healing, there occurs a fibrosis. This is another graphical representation which I have taken from NEJM. So here you can see the cases have been divided as asymptomatic, mild, moderate, severe, and critical cases. So why I have shown up this slide is to give you a clear picture that we are dealing with post-COVID lung sequelae or fibrosis in only patients who have had a severe disease or a critical illness disease. We do not have patients who have, we do not see patients who had post-COVID lung sequelae in a patient who is asymptomatic or who had a mild illness. Say, for example, somebody who is 40 years old, he had only fever, cough, some generalized tiredness, weakness. He didn't have any desaturation at all. He did not have any breathlessness. In him, we are not at all seeing lung fibrosis. So in whom are we seeing this post-COVID lung sequelae fibrosis? Are those patients who required a ventilatory support, an invasive ventilatory support, or a non-invasive ventilatory support, or even in patients in whom there was severe exertional dyspnea and there was drop in saturation and they required around 5 liters, 6 liters, 10 liters of oxygen to maintain the target saturation. So it is what I'm trying to convey here is if we are going to treat the COVID-19 pneumonia properly, then we'll be seeing a less number of cases of lung fibrosis or lung sequelae. We need to understand that in the fibrosis is happening only in patients who have had a severe disease. The sequelae is happening only in patients who had a severe disease. Severe disease, I mean patients who have been on a ventilator or patients who have been on a non-invasive ventilatory support or patients who required a high oxygen support. Say he required 10 liters of oxygen. So the ultimate crux of dealing with post-COVID lung sequelae fibrosis will be preventing the event to happen, which means ideal time we should start medication. Say we should start antivirals, we should start anti-inflammatory steroids, and recently we have the monoclonal antibody cocktail, which is advised to be given in patients who are having multiple comorbidities and who are having only mild symptoms and having only saturation at room air. They do not require any oxygen support. In that condition, we can give antibody cocktail. So rather than looking into how we are going to treat post-COVID lung sequelae, it is better to understand that we are dealing with post-COVID lung sequelae only in patients who have had a severe or a moderate disease requiring ventilator support, invasive or non-invasive, or requiring high oxygen support. So if we avoid patients ending up in NAV and ventilator support, we'll be seeing less number of cases of post-COVID lung sequelae. So that is the most important thing which I wanted to convey through this slide. So radiology of COVID is very important. So as we have been seeing a lot of cases of COVID for the past 2 years, we all know that there is an the early stage where the patient is completely asymptomatic, the ultra early stage where the patient is completely asymptomatic. So even if the patient is going to be asymptomatic, he will have signs or in the CT. For example, the patient is going to have a minimal amount of ground glassing in the CT scan, even when the patient is completely asymptomatic. Then we are talking about an early stage, then we are talking about a consolidation stage, then we are talking about dissociation stage. So this slide is a very important slide. So initially, even before the onset of symptoms, we have signs of ground glassing in CT scan. Subsequently, what happens is in the early stage, what happens is the ground glassing. Ground glassing means, what do you understand by ground glassing? Ground glassing, it is a glass through which you can see the underlying lung structures. Say you can see the vessels very clearly in the CT scan. So here you can see the red arrow mark pointing at it is a ground glassing. Along with that, this top arrow mark, what it is pointing out is an interlobular septa, which is irregular. So septal thickening is beginning to happen. So these are the findings which we do see in a very early stage of the illness. Then the most common findings, what we see in the CT scan is a subpleural consolidation. So what we see as subpleural consolidation is something which we see at around a period of 5th day or 6th day of illness. So even before that, the patient is going to develop ground glassing and interlobular septal thickening. Then the consolidation regresses in size over the 2nd week of illness. Then at the end of 2 or 3 weeks times, what happens is there is going to be a reticular opacities. In simple to concise, to begin with, it is a consolidation. To begin with, it is a ground glassing. Then ground glassing followed by reticular ground glassing followed by septal thickening. Then the consolidation decreases in size. Following the decrease in size of the consolidation, at the end there is going to be a reticular shadow. So it is basically ground glassing, consolidation, and a reticular shadow at the end. End means, I mean to say, at a period of 2 to 3 weeks time. So it is not mandatory that every patient with a COVID-19 pneumonia have to undergo all these stages of pictures, whatever I have described here. We basically need to understand that COVID-19 pneumonia can present as ground glass opacities, can present as subpleural consolidations, can present as septal thickening, can present as reticular shadows, but it appears in different stages of the illness. So what is the pathophysiology? How does COVID-19 pneumonia cause pulmonary fibrosis? So as we all been hearing about, the SARS-CoV-19 pneumonia, it enters the lung through the ACE2 receptors. Once it enters through the ACE2 receptors, there occurs a replication of the virus. And what leads to fibrosis is nothing but our host immune response. A lot of inflammatory cytokines are getting released, because of which there occurs a lung fibrosis. This is another pictorial depiction. This words which I want everyone to remember is myofibroblast activation and ECM, extracellular matrix accumulation. These two are the things which ultimately lead to lung fibrosis. I repeat once again, myofibroblast activation and extracellular matrix accumulation, which occurs as a result of host immune response because of release of large amount of inflammatory cytokines, are going to cause these two pathologies. One is myofibroblast activation, another is extracellular matrix accumulation, and both of which leading to lung fibrosis. So earlier I was telling, post-COVID lung fibrosis or sequelae happens only in patients who have minimum, at least had required an oxygen support, and who have been on a ventilator, say invasive ventilator or non-invasive ventilator. So apart from that, is there anything else which can predict that yes, these are patients who are likely to have a post-COVID lung sequelae or fibrosis, say advanced age? So we don't expect patients who are say 20 years or 30 years of age to have this severe illness first of all, because as we all understand, this COVID-19 pneumonia, the main defense mechanism is our own immunity. Our own host immunity is the most important thing for us for getting escape from this illness. So elderly people who have had multiple comorbidities, say he is a COPD, he is having a cardiac illness, he is a CLD, patients with multiple comorbidities, and patients who had prolonged ICU stay and hospital stay. So we don't expect patients, say for example, patients got admitted, he had only mild symptoms, so he had only fever, cough, breathlessness, and he didn't have any breathlessness, he had only fever, cough. Subsequently, his saturation was all normal, his inflammatory markers were all normal. So he's completely asymptomatic and he got discharged home, which means we don't expect that person to have a post-COVID lung sequelae fibrosis. We expect post-COVID lung sequelae fibrosis in patients who have had a prolonged prolonged hospital stay with requirement of oxygen. Say, for example, he has been requiring around 10 liters of oxygen on day 1 to maintain adequate saturation. But at the end of the hospitalization, say when he is getting discharged home, still we are not able to get him out of oxygen. So we are discharging him home with oxygen. So those are the patients in whom we expect to have post-COVID lung sequelae fibrosis. Along with that, patients want mechanical ventilators and non-invasive ventilator supports. Along with that, important things are history of smoking, because underlying lung parenchyma is already damaged. So COVID-19 pneumonia entering a lung which is a healthy lung, say he is not having any respiratory related illness and he is a non-smoker, whereas someone who has already had a severe COPD disease, already having an interstitial lung disease, and already having smoked a lot, because of which this underlying lung parenchyma is damaged, in them they are potential candidates to land up in lung fibrosis. So in this slide, we can see that the higher level of CRP and IL-6 during the illness might lead to formation of fibrosis during the recovery. But regarding this, we need to see in detail. Much papers are yet to come with which we can give a stronger comment on that. So I'll be discussing a case for us to understand things. So here we see a CT scan of a 66-year-old female who is right now currently in our management. She's been admitted in our hospital, in our ICU, and she's on a mechanical ventilator. So you see here the CT scan around 8th of August. Say there is presence of ground glass opacities. Again, the patients initially when she came in, she was requiring an oxygen support, but she, on spite of treatment with antivirals and steroids, her oxygen requirement continued to increase. So we did a repeat CT, but this time what we did a CT pulmonary angiography to make sure that we are not missing a pulmonary embolism. And in spite of treatment with steroids, in spite of treatment with the appropriate dose of antivirals, she started to develop some reticular shadows, and oxygen requirement worsened, which means clinically she worsened, say over a period of 1 week time, she clinically worsened, her oxygen requirement went very high. Again, the CT picture of the same patients within 1 week interval, say from the CT scan on around 8th, it shows only some amount of ground glassing. But here you see whatever areas there was ground glassing, now it is going to get converted into a reticular shadows, which means something like a net-like shadows are seen, which means the disease is progressing and disease is advancing. It is the same CT scan of the patient done on 8th and done on 14th. We are looking at the same level, looking at the same cuts in the lung. So what we are seeing here is whatever is seen as ground glassing in the CT scan done on 8th, that has been converted into reticular shadows. Which means she is somebody in whom we can predict that since her oxygen requirement has went up in spite of treatment with optimal dose of steroids and antivirals, and she is clinically worsening and radiologically also worsening. So she is somebody who's a potential candidate who can end up in fibrosis. So what happened with this patient was we were able to taper the oxygen requirement of this patient up to 3 liters, and we had sent the patient home with 3 liters of home oxygen. So what happened subsequently is she came to us around 2 days back. You can see this is a CT scan of the same patient. So this time what happened is she had an exertional dyspnea, following which there was significant desaturation. So we did a CTP again to make sure that we're not missing any pulmonary embolism. So she had a pulmonary embolism, but it was looked at very distally. It was looked at very distally. But you see, the initial CT scan was done only 1 month back. Now it is within 1 month interval, she has gone into she is developing subpleural fibrosis. So whatever was seen as a ground glass opacity in the initial period is now getting converted into a fibrosis. So what we need to understand is this COVID-19 pneumonia is a disease where the fibrosis is getting so rapid. We have not come across diseases which causes the lungs to have fibrosis within a period of 1 month. So within a period of 1 month, the patient has standed up in fibrosis. So that is what is something which is very much worrisome about this disease. As you also see here, there is evidence of pneumomediastinum. You see here, there is evidence of the patient is intubated. There is evidence of pneumomediastinum here. So pneumomediastinum is one another complication which we face in patients of say COVID pneumonia when we are intubating them, and even in non-invasive ventilator supports, patients end up in the subcutaneous emphysema. Here you can see there is some amount of subcutaneous emphysema, and also there is pneumomediastinum. The same patient's picture, see, just 1 month interval, she's a 66-year-old female. She didn't have any prior respiratory illness, but you see the extent of fibrosis is very significant. The extent of fibrosis is very significant. This is just to make you understand that whatever initially appearing as ground glassing, in spite of the proper treatment, there are conditions where the patient's condition is deteriorating, and they ultimately ending up in having a lung fibrosis in spite of treatment with optimal doses of steroids and antivirals. So what will be the further plan of management? Are you going to give antifibrotics alone, or you're going to give steroids alone? If steroids, are you going to give intravenous steroids, or are you going to give oral steroids, or you're going to combine both fibrosis and antifibrotic as well as IV steroids, or antifibrotics plus oral steroids in tapering dose? So you have all these in your armamentarium. So what are we going to choose? We'll get to know at the end of the presentation. So these are the radiological features of post-COVID lung pneumonia. So various things are described here. It'll be better if I show these as pictures to you. I'll be showing it to you in the subsequent slides. This is another case scenario. So in the first case, what we saw was 66-year-old female. and she had a severe COVID. I won't say severe because she did not require any ventilator support. She required only high amount of oxygen support. So I'll better call it as a moderate COVID. So the previous case was a 66-year-old female who did not have any prior respiratory illness, and she had a moderate COVID, and she eventually progressed to fibrosis. So this is case number 2. So this case is also was also managed by us in a hospital. So this patient came to us by March. So this patient came to us by March. So you see here the CT scan which is done on March is showing that there's presence of a ground glass opacities here. So the subsequent CT scan which is done maybe around a period of say 29/6. So exactly after 1 month interval the CT scan is done. You can see most of the shadows are completely resolved. So whatever is seen here as ground glassing, it is completely, I would say around 70% it has got resolved completely within a period of 1 month time. Then subsequently what happened is we followed this patient, and again this CT scan is again done after a period of say 28/8. So the initial scans, whatever we have seen, the initial scans. So this patient had a CT scan at the end of May, and we followed up in June where the shadows were resolving. And you see in July and August, so end of May, say June, July, August, so 3 months period. So 3 months follow up, there is a complete clearance of the lungs. There is no evidence of fibrosis, and very little shadows, I would say reticular shadows are present. So here the patient managed in our hospital as per the protocol, which the same patient, previous patient was managed. So this patient, we can find in a period of 3 months interval, there is complete resolution of shadows. But the previous patient was a 66-year-old female. She, within 1 month time, she had progressed to severe lung fibrosis. This is a CT scan of the same patient, but done at the end of August, which means after 3 months time, there is almost a complete resolution of every shadows. So what I'm trying to convey to you is, it is not that every patient who required significant oxygen support on required ventilator support or ultimately should eventually end up in lung fibrosis. It is not the case scenario. So this is an article from say Lung India, which say that there are 3 pathways through which this lung COVID pneumonia can progress. One is improving, which is the most common one. Second one is static, which is less common. The one which is of concern to us today, and which is what is it? It is a many patients end up in that condition, that is the post COVID lung sequelae. So this is the group which we are concerned about, because these are the patients who are not able to carry out their routine life activities because they have severe exertional dyspnea. Even many of the patients are still on home oxygen support. This is another study which is published in another article. So look at these graphs. So they have looked at 2nd week, 3rd week, and 4th week. These are all COVID patients. 2nd week, what happens is significant amount of reticulations. Yellow color represents reticulations, white color represents linear shadows, whereas blue color represents ground glass opacities. So as we follow the patients over a period of 4 weeks time, what happens is this ground glass opacities have got significantly reduced. The irregular linear opacities have also got significantly reduced, and reticular opacities also got significantly reduced. So as per the protocol, if you treat the patients, as per the protocol means you are giving antivirals, you are giving steroids on patients who require oxygen support. I repeat once again, I am giving steroids only to patients who require oxygen support. I'm not giving steroids based on CRP. I'm not giving steroids because the patient had a COVID-19 pneumonia and he has a CT severity of say 10 out of 25. Steroids are supposed to be given only in patients who are hypoxic. Steroids, when given at an early stage of illness where there is no hypoxia, can suppress the host immune response and it can end up in viral replication. So I'm repeating the same thing which I told earlier. It is always better to prevent the post-COVID lung sequelae from happening rather than the sequelae or fibrosis happening and then worrying about how to treat it. So as we observe here, over a period of 4 weeks time, eventually what happens is most of the shadows, it regresses on its own. And this clinically also they are improving, radiologically also they are improving over a period of only 4 weeks, which means over a period of 1 month time, all the shadows which are seen in the CT scan are getting reduced significantly. So we'll move to another case. So this patient is a 52-year-old male. So here the CT scan done on March, the second one is done on May, around 1 month interval. But you see in the ground glassing here, just like a glass, it is seen. You can see the underlying structures. Whatever is seen as ground glassing here it has progressed to some amount of significant reticular shadows. And we are looking at the lungs at the same level. I'm showing the same picture of the lung on the both sides. So within a 1 month interval, what has happened is whatever is appearing as ground glassing is subsequently gone into reticular shadows. Subsequently, the same patient, same images, but at a lower down level I'm showing. So you can see the right main bronchus, left main bronchus. Here also right main, left main. Here whatever is seen as ground glassing, in this you can see it is progressed into reticular shadows, which means it is about to land up in fibrosis. Same patient. Here at the base of the lungs, you can see ground glassing. Whatever is seen as ground glassing, glass-like thing is getting converted to reticular shadows. Reticular means it is subpleural. You are seeing reticular shadows. The same patient in after a period of follow-up, this is 36. So the previous CT scan on, so initial CT scan is on 24, March 20, then May, mid of May, around 1 month interval. So, April and May. April and May, in April it is ground glassing, in May it is becoming reticular shadows. We thought he will progress into fibrosis. So the CT scan under the end of June, there is complete resolution of shadows. There is complete resolution of shadows. It is a almost normal lung. So this is another clinical scenario. This is the third case. This is another third case I'm showing you today. The first case eventually ended up in fibrosis. Second case and third case, they are having fibrosis, but eventually the fibrosis is getting cleared. So this is another interesting article which I recently read. So the pulmonary sequelae in patient discharged with COVID-19, a short-term observational study. So in this, you see from the graph, what you can understand, blue lines, the blue line represents ground glassing. So what happened? Initially, all the patients had at the time of discharge, they're saying at the time of discharge here, all the patients had a ground glassing, but subsequently what happened is all the ground glassing significantly got resolved in the third CT. The same thing with appears to fibrous stripe, the fibrous strands, that reticular shadows what we're describing, that also is getting regressed. Third thing, whatever radiological picture they have seen, what they have noticed is over a period of follow-up, what happens is all the shadows, they regress in size. So you see in this picture, ground glassing here in picture A is getting resolved in picture B. Similarly here, the fibrotic strands, I look at my mouse pointer where it is pointing out. So these structures which is seen here are all getting completely cleared. So ground glassing is getting disappeared, these fibrotic strands are getting disappears. So this is not this is case one, this is another case. So she's an elderly female. She was treated with remdesivir, NIV, and IV steroids. She was on 4 liters of oxygen. She had weaning difficulty. So within a period of say around 10 days interval, what has happened is whatever is seen as a ground glassing here, on 20th May, it is turning into reticular shadows. You see here there's some amount of reticular shadows. Here in CT scan, we can see that she has progressed into lung fibrosis. There's another patient, 50-year-old gentleman, severe disease, managed with steroids, remdesivir, and NIV support, followed up in OPD with significant improvement, but still he is having a saturation of 88 to 92% in room air, and that's persistent tachycardia. So now we are dealing with a post-COVID patient who has come to us for a follow-up. He has had a severe disease. He was on a ventilator support and he is now under our follow-up. He has come to our OPD. His saturation is only 88 to 92 in room air, but there is persistent tachycardia. So X-ray is looking apparently normal, not much. I mean to say, not much of a significant post-COVID sequelae is not there in this CT, in this chest X-ray image. So in these patients where the X-ray is quite normal and there is significant desaturation and there is significant exertional breathlessness and there's tachycardia, you have to look for other causes. So as we see here in the CT scan, you can see there is evidence of his lung parenchyma is getting cleared. His lung parenchyma is almost normal. I would say there's very little evidence of post-COVID lung sequelae in him, but there is evidence of pneumomediastinum. So it is not that every patient of post-COVID lung sequelae or breathless only because of the lung parenchymal involvement. Because the lung parenchyma is severely damaged and there's a persistent cough in them, there can be a pneumothorax and pneumomediastinum happening. So always look for other causes like pneumothorax, pneumomediastinum, and even pulmonary embolism, which are very frequently common in patients with post-COVID lung sequelae. So elderly woman managed for severe COVID pneumonia in another center. She was referred for breathing difficulty and persistent hypoxia and breathing difficulty. So this patient came to us. This X-ray is looking very quite bad. You can see there is bilateral ground glassing as well as reticular shadows in both sides of the lung. This is a CT scan. So again, this is a similar picture. See, the lungs is also involved. Along with it, there is evidence of pneumomediastinum as evidenced here. So it is not that only post-COVID lung sequelae means only lung fibrosis. We have to always think about two other differential diagnoses. One is involving the pleura, which is the pneumomediastinum and the pneumothorax. One is involving the pulmonary vessels, that is a pulmonary embolism. So these two also can significantly contribute to breathlessness. So this article published in Lung India, what it says is this lung fibrosis is not something which is needed to develop in patients with lung already having a lung physiopathology. So this patient, no history of lung disease, and within a period of 1 month time, she has developed traction bronchiectasis, and these things, traction bronchiectasis means fibrosis. These things occurred in spite of her being on steroids in most of the hospital, in her hospital stay, which means what they are trying to convey is, in spite of adequate dose of steroids and in spite of the underlying lung being normal, there are patients who develop lung sequelae. So we'll talk about nintedanib. So this basically is a tyrosine kinase inhibitor. So tyrosine kinase inhibitor. So basically what happens is the fibroblast proliferation is getting inhibited. Fibroblast proliferation is getting inhibited. One thing which I want every one of you to understand is, if you are starting a patient on antifibrotic, your ultimate aim is just prevention of progression of fibrosis. I repeat once again. Say, for example, I am treating a patient of interstitial lung disease, not post-COVID pneumonia. I'm saying I'm dealing with an idiopathic pulmonary fibrosis, IPF. I'm dealing with idiopathic pulmonary fibrosis. He has come to me and I have diagnosed him to have idiopathic pulmonary fibrosis, and I'm starting the patient on antifibrotic nintedanib. So what I should be clear and what I should explain to the patient is that I'm giving this drug only for prevention of progression of fibrosis. I am not giving this drug for so that the fibrosis is getting healed. Fibrosis in layman term, it is a scar which has already happened. So you cannot get back the scar to its normal tissue, which is not possible. So the ultimate aim of giving nintedanib is, or pirfenidone, is just prevention of progression of the fibrosis. Our ultimate aim should be that the patient's fibrosis, if you are going to do a CT scan now and diagnosing this case as idiopathic pulmonary fibrosis, and after a period of 6 months time, you are doing a repeat CT scan and you are finding that the fibrosis is the same to the same extent what it was there earlier, which means you have done a good job. Because you are not expecting the fibrosis to get resolved completely. In other ways, we can monitor the FVC. in pulmonary function testing, we do the FVC. In FVC, the ultimate goal is the FVC should be remaining static. It should not fall down below 10%. If there is a fall down of below 10% of FVC in idiopathic or in interstitial lung disease, we call it as disease progression. So why I am saying this to you is nintedanib is a drug which is given in cases of interstitial lung disease, idiopathic pulmonary fibrosis especially, or in cases of say a patient is having a scleroderma, he's having a scleroderma, a conductive tissue disorder, along with that he's having a lung fibrosis. In him or her, if you're giving nintedanib, your ultimate aim is just prevention of progression of fibrosis, and his lung volume, his post vital capacity should remain the same as what it is currently now. You're not looking at something which is completely reversible. You're not looking at something which is completely curable. You're looking at some drug which will just halt the progression of this fibrosis. This everyone should be very clear about. So earlier I was talking about this ECM, extracellular matrix, and how this nintedanib works is nintedanib works by inhibiting the proliferation of fibroblast and thereby a reduction of deposition of extracellular matrix in the lung. Earlier we saw that say the myofibroblast proliferation and extracellular matrix in the lung is going to cause pulmonary fibrosis. So nintedanib is something which prevents the proliferation and deposition of fibroblast and deposition of extracellular matrix in the lung. So every patient of mine, if I start them on antifibrotic, they ask me a question, sir, are there any evidence? Are there any evidence to say that yes, antifibrotics have been proven to prevent the disease progression in patients with post-COVID lung fibrosis? My answer is, at present, we don't have any clear-cut guidelines or consensus to say that yes, these are the group of patients in whom we should start them on antifibrotics. There are two drugs already in the market. One is nintedanib, one is pirfenidone. I would prefer pirfenidone for one main reason, because the dose of the drug is very less. It is one capsule in the morning and one capsule in the night. Whereas when it is compared to pirfenidone, we have to give a minimum dose of 2,400 milligram, which means it comes as a 800. Now recently it has come as 800 mg tablet. So patients need to take 2 tablets in the morning and 2 tablets in the night. So it is better that patients go with nintedanib, because the capsule bill burden is less in case of nintedanib. So in this slide, what I'm trying to convey to is, till now there is no guidelines, there is no consensus to say yes, this patient is a severe COVID patient, he will eventually land up in fibrosis, so give this patient antifibrotic. There are no clear-cut guidelines. Trials are ongoing. The reports are results of which are still awaited. So as discussed earlier, so when comparison between nintedanib and pirfenidone, earlier separation of FVC decline curves and faster onset of action, which means there is a better improvement of FVC with nintedanib, and the drug is having a very faster onset of action. It is good that the Indian companies have bought this drug. Previously, maybe around say 2 years before, every patient of interstitial lung disease, especially idiopathic pulmonary fibrosis, will be only on pirfenidone, because this drug was a very costly drug, and it was very few people. I mean, we can count in numbers. We'll have only patients whom we can count in numbers. Only those much patients will be getting nintedanib, because it is a very costly drug. But now the Indian market has generic brand has come, so we are using for our Indian patients. Already, as already discussed, the dose of nintedanib is very easy for the patient. 1 tablet in the morning and less, so the adherence of the patient will be less. But there are chances in pirfenidone, maybe that seems because pill burden is high, they might skip the drug. So this is the last case which I'm going to show to you. So here we are seeing a CT scan on June 28th, and subsequently we are seeing here a CT scan which is done on after 2 months time, almost the same date. You can see there is significant resolution of shadows. Here there are much reticular shadows. Those reticular shadows have gone significantly gone. It's disappeared completely. Again, here you can see the same images of the same patient. One is done in June, one is done in August. You can see that there is significant resolution of symptoms. Again, the same picture. Thus, you can see there's a drastic improvement of in clinically also the patients improve, and radiologic also you see what this patient, whoever sees that this patient will see on seeing the CT scan, they will say that yes, he is somebody who is going to land up in lung fibrosis. But here you see that those things are not happening. So the fibrosis is not happening, and eventually the lung is getting completely cleared. Even though there are subtle shadows, but honeycombing is something which is needed and for us to say there is significant amount of lung fibrosis. Those shadows are not there. Honeycombing is something very typical and characteristic of lung fibrosis. That is not happening here in case of post-COVID pneumonia. So how many post-COVID interstitial lung disease we have seen? We have seen lots and lots of patients of post-COVID interstitial lung disease. So is there any clinical markers or clinical parameters to identify COVID patients eligible for antifibrotics? My genuine answer is no. Based upon the clinical, radiological, and oxygen requirement, exertional dyspnea, these things will help us decide, yes, this patient is somebody who is eventually going to land up in lung fibrosis. Any specific high-risk group which shows greater propensity for development under progression of post-COVID fibrosis? Yes, those patients who have had ventilatory support, those patients who have had non-invasive ventilator support or invasive ventilator support, or patients who are who have been in the hospital for a longer period of time due to a requirement of high amount of oxygen. Say he was initially requiring 50 liters of oxygen, but gradually, say over a period of 2 weeks time, we are able to taper the oxygen and he was discharged home with 5 liters of oxygen. Yes, he is somebody who will end up in lung fibrosis. And as I already discussed, smokers or elderly people with other multiple comorbidities or patients who can end up in lung fibrosis. HRCT role, it is mandatory that, say, I will not do CT for a patient who is completely not having any breathlessness. In a patient who is having only fever, cough, generalized tiredness, weakness, and is a young adult who doesn't smoke, does not have any comorbidity, I'm not going to achieve much by doing an HRCT in him, because the management plan for him is just a conservative management. Our body's own immune mechanism will take care of his illness, so I'm not going to do a CT scan in him. But for example, I'm dealing with a patient who has been on a mechanical ventilator or has been on a non-invasive ventilator support, or he is someone who is having high oxygen requirement. Say he required 15 liters of oxygen, and we are dealing with patients whom we are discharging home with home oxygen. It is always better to have a CT scan done. If you are suspecting a pulmonary embolism, it is always better to do a CT pulmonary angiography and a HRCT thorax in those patients at the time of discharge, so that when they come for follow-up, say we can follow up in a period of 2 weeks time or 4 weeks time. We do over a period of 1 month time, 4 weeks time to look for resolution of symptoms. So at the time of admission in the 5th day or 7th day, you have to get a CT done in patients who are requiring oxygen support, and in patients, the same patients who got sick, required high ventilatory support, required critical care support. At the time of discharge, it is always wise to do a CT to get to know what is the picture. During subsequent follow-up, if the patient is still continuing to have breathlessness at a period of 1 month time, it is justified to get a CT scan done for them. So what is the ideal time to start antifibrotics to prevent retard progression of fibrosis? In whatever study and trials are done, with respect to antifibrotics, the antifibrotics kick in. The role of antifibrotics only comes in after a period of 4 weeks after initiation of the treatment. For example, if I diagnose a case of idiopathic pulmonary fibrosis today, and I start the patient on nintedanib today, it is not that tomorrow the drug is going to come into action. It will take minimum 4 weeks time for the drugs to come into action. So From whatever cases we have seen, we have discussed today, in my experience, what I can say is many patients, I would not say all patients, many patients who have had a severe disease, who have had a high oxygen support during admission, who have had a ventilator support, invasive or non-invasive ventilator support, whatever patients whom we expected them to have a lung fibrosis, eventually they ended up their lung CT scan, and clinically they have a significant improvement. And CT scans, after a period of 3 months time follow-up, they were almost getting cleared, but not for every patient. I would not say that every patient is COVID who had a COVID-19 pneumonia severe disease did not have any sequelae at the end of 3 months time. Yes, we do have patients who have having honeycombing in CT scan at the end of 3 months time, but it is not clear. After treating so much of patients, we are not able to predict, yes, these are the patients who had a severe disease who are going to end up in lung fibrosis. And these are the group of patients who have had a severe disease, and they are patients who will not have lung fibrosis. We are not able to clear cut demarcate them. To understand this, we need to have a head-to-head study. Say one group with a severe COVID pneumonia, in whom we are suspecting them to have a severe uh, fibrosis, and initiate them on antifibrotics. In another group, what we need to do is we need to have two groups. One group is a group with COVID-19 pneumonia, severe disease, suspect pulmonary embolism. Give them antifibrotics for a period of 3 months time, 2 months time. Another group, you have severe COVID pneumonia, same pulmonary fibrosis in CT scan. Give them for a period of say 4 weeks time. At the end of the 3 months time, we need to calculate the lung function. We need to assess the CT scans. Then only we can give a clear-cut idea regarding whether antifibrotics ideally will help us in improving the lung condition or not. So what I'm trying to convey is we are yet to find out whether which are the group of patients who will eventually land up in lung fibrosis. There are many patients whom we have handled, whom we thought, yes, he will ultimately end up in lung fibrosis. There are patients whom I would say maybe 20 patients I would have handled. I discharged home with 5 liters of oxygen. Everybody I have, they're completely now without oxygen support. They're able to carry out all their routine activities. But it happened over a period of say 2 months time. It is not that immediately it happened. Every patient of mine whom I suspect to have a severe COVID pneumonia, who suspect to have severe lung fibrosis, I have discharged them with home oxygen, but eventually over a period of 1 month time or at the max 2 months time, I'm able to completely take them off oxygen. The most important thing to them is pulmonary rehabilitation, physical activity. Those things are most important for them, because those patients are patients who have been in ICU for a longer period of time. You would have given them a lot of muscle relaxants. You would have given them a lot of anesthetic agents. So all their muscles would have got fragile. You need to get them back into proper shape. So pulmonary rehabilitation is one of the most important thing. Preferred antibiotic is pirfenidone, nintedanib, but I would prefer pirfenidone, especially for the bill burden. So how long to continue antifibrotic therapy? Usually in my practice, what I do is I am someone who start antifibrotics on patients who have had a severe COVID disease, and who are having signs of fibrosis in CT scan, who are having signs of traction bronchiectasis or bronchiectasis in CT scan, and still continue to have breathlessness. In them, I have started antifibrotics, and when I stop this is at the end, maybe after 3 months time, once I get a CT scan, then to check if the shadows have resolved completely. In them, I consider stopping it. So the duration it's not fixed. It cannot be fixed for everybody. It has to be tailor-made. But I repeat once again, there are no guidelines, there are no consensus to guide us. Yes, these are the patients in whom you need to give antifibrotics. So in whom we suspect pulmonary fibrosis, there is unexplained or disproportionate hypoxia, and patients who had a severe COVID pneumonia and he had been on ventilator for a very longer period of time. And radiology is very important for detection of lung fibrosis. So we need to be very good at reading HRCT scans. So patients continue to be discharged with home oxygen. So these are the patients in whom you suspect them to have pulmonary embolism. But as discussed earlier, not every post-COVID pneumonia patients have pulmonary fibrosis as the cause of dyspnea. They might even have a pneumothorax, pneumomediation, or pulmonary embolism, or even they might have a secondary lung infection, especially fungal infections or consolidations, because we are treating patients with steroids. So look for that also. So crux, what I'm trying to convey to you all is management of post-COVID sequelae. Number one will be oxygen. If the patient continues to remain hypoxic, if it's, you can keep a target saturation of 94%. If the target saturation of 94% is not achieved, send them home with home oxygen. That is number one. Always they need to keep their saturation above 94%. Most important thing is pulmonary rehab. We have treated patients with ECMO and we have got them out beautifully. And now they have started doing their activities on their own. Most important thing for them to get back to their normal is pulmonary rehab. Many patients have been referred to us, say they got discharged from a hospital, they have been asked to be bedridden for a period of 1 month. So that itself will cause all muscle weakness. So what should be encouraged is minimal physical activity along with oxygen support should be there in any patient who have there a severe COVID pneumonia, so that their muscles are getting routinely trained. There is enough amount of perfusion happening in their lungs. If many patients, what they do is they had a very severe COVID pneumonia, they have got discharged, they stay at home, they are bedridden for a period of 1 month time. See, COVID is per se a prothrombotic state. If you're going to give the patient bedridden for a prothrombotic, for a period of 1 month time, obviously you are giving a chance for a pulmonary embolism to happen. So most importantly, they need to be active, they need to be mobile. Not to that extent to cause severe breathlessness, but at least to carry out their routine basic activities. Pulmonary rehabilitation, physiotherapy should be very much encouraged. This is something very important, and in fact, I would say it is the most important. Rather than say giving them steroids, giving them antifibrotics, pulmonary rehab, physiotherapy is very, very important. Not every patient, COVID pneumonia patients needs to be given complete bed rest. They need to be active. They need to be given a lot of physio to get their muscles get back to their normal. Vaccination. Any post-COVID sequelae patient, they are at more risk of infection when compared to others. So it is important to get them vaccinated with the influenza and pneumococcal vaccination. Then, as I discussed at the initial beginning of the talk, it is always to prevent the post-COVID sequelae rather than treating it. So modest dose of steroids given in the right time will prevent lung fibrosis. So the best part to prevent lung sequelae or fibrosis is to treat the COVID properly with the adequate dose of steroids. Antifibrotics, we are yet to get a clear-cut consensus and guidelines, but based upon a clinical and radiological decision, we can start the patients on antifibrotics. So my take-home message is, whenever patients is hypoxic, you need to give them IV steroids. Tapering of steroids is very important because we had seen a lot of cases of black fungus and a lot of cases of secondary lung infection because steroids were continued for a longer period of time. So early identification of fibrosis. So you need to early identify the fibrosis. So for example, patient is continuing to remain hypoxic, you're not able to wean them off oxygen support. So you need to understand why he's still on oxygen support. So for that, you need a HRCT thorax, or you're expecting a pulmonary embolism, suspecting a pulmonary embolism, you need to do a CT pulmonary angiography. Role of oral steroids in tapering dose, yes. Especially in patients whom you're discharging with home oxygen support, and if there is evidence of significant ground glassing in the CT scan. I repeat once again, you are dealing with a COVID patient who has been with you for quite some time, and at the end of the day, when you're discharging the patient, you're doing a CT scan and you find there is significant amount of ground glassing, then you can give them a low dose of oral corticosteroids and say taper it over a period of 2 weeks or 3 weeks at the max. So antifibrotics, as said earlier, clear-cut guidelines yet to come. But yes, based upon the clinical and radiological decision, it must be started early, because as I told earlier, you are giving a drug to prevent the progression of fibrosis. You are not giving a drug to reverse the fibrosis. And we have discussed that it takes 4 weeks for the drug to kick in. So early you should identify the fibrosis and you should start it early. So these things we have already discussed. So look for other causes like pneumothorax, pneumomediastinum, pulmonary embolism, and we should be careful in the dose of steroids what we are giving, because we had seen a lot of cases of aspergillus and mucor. Thank you, Anand. I'm happy to take any questions.
Thank you very much, sir. Audience, if you have any questions, please type in the chat box, or you can unmute yourself and ask the questions.
Feel free to ask any doubts, doctors. Anything is fine in regarding cases which you have dealt with.
Audience, it's a good time to get our doubts cleared. So if you have any questions, please type in the chat box or unmute yourself and ask.
So this post-COVID sequelae, the most important thing what I would recommend is pulmonary rehabilitation, proper nutrition, vaccination. These are the things which help them revert back to normal. Many of the cases which we have seen as severe COVID pneumonia, they have recovered well with physio, rehab, good nutrition and oxygen support. We are able to taper them of oxygen support over a period of max 2 months time. So as I said earlier in the beginning of the talk, initially it was thought to be a post-COVID fibrosis, but now I think most of you will agree with whatever cases I have shown you. It is better to rename them it as post-COVID lung sequelae and not call as fibrosis, because this fibrosis is something which is setting in over a period of 1 month time, which doesn't happen in any of the diseases which we have seen earlier. And in none of the interstitial lung disease which we have been treating routinely, none of the diseases the fibrosis resolves. If in idiopathic pulmonary fibrosis, once the fibrosis occurs, once there is honeycombing the CT scan will continue to have honeycombing. Whenever you do a CT scan over a period of 5 years, 10 years, 15 years, it will be always there. It will never get completely resolved. But here we have seen that the fibrosis, whatever we have seen, is getting resolved, which is something new for us.
Correct, sir. Thank you very much, sir. Sir, I do not see any further questions coming in.
Okay.
With this, sir, we come to the close of this session. Thank you very much for this elaborate presentation, along with your personal cases which you have shown. It was a good learning experience, I'm sure, for everyone. Before we close this meeting, sir, we wanted to highlight our brand, which is Nindanib 100 milligram and 150 milligram. I would request all the delegates who are present, please use it in the right set of patients and do share your experience with us. With this, we come to the close of this session. Would like to thank Dr. Vijaya Arvind for giving us a good learning experience today, and also all the delegates who have attended the meeting. Thank you very much.
Thank you, Anand. Thank you.